Hello, this is Jeff Swenson. We'd like to take a few moments to show you an instructional video on the use of a new fenestrated needle for fascial plane approach to peripheral nerves. We would like to specifically deal with the femoral nerve block in this video. In light of the fact that many major nerves in lower extremity are positioned in well-defined fascial planes, we can use this anatomic fact to our advantage to be able to block the nerve from a safe distance. The design of this needle includes a pencil point which provides visual and tactile feedback of tissue planes as the anesthesiologist advances the needle through tissue planes. It also is relatively atraumatic to vessels and nerves compared to conventional beveled needles. The side fenestrations, as we mentioned earlier, provide improved distribution of local anesthetic into fascial planes. And the design with side fenestrations and a pencil point prevents intraneural or intravascular outflow from the needle tip of local anesthetic. There are three design options available for this needle: a 1 centimeter segment of fenestrations, a 2 centimeter segment of fenestrations, and a 3 centimeter segment of fenestrations. In this particular video, we'll be using the 1 centimeter segment of fenestrations for the femoral nerve block. We have three broad areas that we'd like to consider. First, proximal saphenous or adductor canal blocks, the sciatic nerve at the popliteal fossa, or the femoral nerve. In this case, we're going to deal with the femoral nerve. If we look at this artist rendition of the inguinal region, we can see that the fascia iliaca overlies the iliopsoas and femoral nerve laterally and then passes medially deep to the femoral vessels. A former method of performing this block included advancing a needle directly in line with the nerve. Unfortunately, with this technique, there was a possibility of causing painful paresthesias and possibly nerve injury. An alternative to this approach is to advance a needle 1 to 2 centimeters lateral to the femoral nerve, either in plane or out of plane, and using hydrodissection to inject local anesthetic into the tissue plane between the fascia iliaca and the femoral nerve, thus achieving a block without trauma of the needle to the nerve. This is a nice technique, but it can be difficult to perform. The advantage of the fenestrated needle is that as we advance the needle through the confluence of the fascia lata and fascia iliaca, we can inject the local anesthetic through multiple side ports, which will preferentially distribute local anesthetic in tissue planes. In this case, the plane deep to the fascia iliaca. This is a fresh cadaver dissection. If we look on the right panel, you can see that the fascia iliaca is intact, and I'm holding it with my pickups. If you look very carefully, the translucent fascia iliaca overlies the femoral nerve, and you can see the femoral nerve very vaguely through this tissue layer. On the left, the fascia iliaca has been cut inferiorly, and the margin of the fascia iliaca is demonstrated by the three black arrows. This illustrates the proximity or the tight adherence of the fascia iliaca to underlying structures such as the femoral nerve and the iliacus muscle. In other words, it's very, very challenging sometimes to position a single bevel needle exactly in that tissue plane. This is an example of a femoral nerve block being performed with a single bevel traditional needle, showing us how we can have difficulty identifying the correct fascial plane if we're injecting lateral to the nerve with a single bevel. As we go live with this video, you'll see the needle indent the heavy confluence of fascia iliaca and fascia lata here, and as we inject, there's definitely a tissue plane appearing. However, the local anesthetic is spreading superficial to the nerve and superficial to the artery, which is the wrong plane. The operator then advances the needle slightly more deep and does in fact locate the correct fascial plane. And as we inject more local anesthetic into this plane, you'll see that the local anesthetic passes over the femoral nerve and deep to the femoral artery. As I mentioned before, though, this can be difficult to achieve in a real-time setting. This is an interesting view because all we are trying to demonstrate in this view is how the pencil point of the fenestrated needle is valuable in helping us identify tissue planes both visually and with tactile sense. In this image, we see the femoral artery, the femoral nerve. If we look at where our insertion point would be lateral to the femoral nerve, we can see that a safe place to advance the needle would be in the lateral third of this image. If we use the corresponding site on the ultrasound transducer, specifically the lateral third of the transducer, this will allow us to advance our needle in a position that will not endanger the femoral nerve. In other words, we can assure ourselves by matching these two pictures that we can insert our needle lateral to the nerve and not directly over it. Now, as we go live with this, you will be able to see the pencil point needle first tenting the fascia and then popping through. So here we are tenting, then the fascia gives way, and this indicates to us that the bevel has just passed through the fascia, the confluence of the fascia lata and the fascia iliaca. This is an actual injection in the inguinal region using a 1 centimeter tip fenestrated needle. Once again, we identify the femoral nerve, the femoral artery. We use the fenestrated needle to pass through the confluence of the fascia iliaca and the fascia lata. And once again, as we look on the screen, we see that the lateral portion of the image corresponds to where we should insert our needle laterally relative to the transducer to avoid contact with the nerve. So as we perform this injection in the lateral third, we see local anesthetic, some of which, after we tent through, some of the local anesthetic will in fact exit superficial to the desired plane, but the vast majority of this local anesthetic exits in the plane deep to the fascia iliaca or in the correct fascial plane. And at the completion of the injection, there is a large amount, in fact the predominance of the local anesthetic is in a tissue plane which is superficial to the femoral nerve but deep to the femoral vessels, illustrated by this outline. Thank you.